Ladies and gentlemen, you can always tell when things have got desperate, when they ask me to stand up to the plate. And as you can see there, they made me president of the Catholic Medical Association. Things have really got desperate. Never trust a doctor with a law degree. And certainly don't trust a doctor who can't spell. When I became a doctor 38 years ago, we had the dark shadow of the Abortion Act. That came into law before I was qualified. And that has cast a dark shadow for 40 years over the practice of medicine in this country. I hope those of us that have opposed it will not be blamed for it. I hope that over the last 40 years we have been able to hold that thin red line. You, the next generation, my son's generation, my nephew's generation, my niece's generation, my son-in-law's generation, junior doctors, must break through that thin red line. The last talk illustrated how that can be done. You will succeed in ways that my generation did not succeed. But you will succeed. You will succeed with your enthusiasm, your energy, your sensitivity to these issues. And one of the most remarkable things, as I hope to illustrate, that has happened recently is the defeat of the Maris bill on Friday, a hot Friday, when the MPs had just come back to Parliament, by 300 votes to 118. That is a remarkable result. And what I'm going to try and do in this talk is to explain, if possible, the practical, the intellectual, the clinical, the political issues that might help you to try and understand that remarkable turnaround. It goes against a trend in Europe and North America. It is a remarkable fact. Never trust a doctor who can't work his own computer. There we go. I'm going to start with an introduction, which is also my conclusion. The whole thing is remarkably simple. The whole issue in relation to euthanasia, physician-assisted suicide, assisted dying, is very simple. It was summarized in the Hippocratic Oath. I will give no deadly drug to any, nor will I counsel such. Complete prohibition on direct, deliberate killing. And wheresoever I go and whosoever house I enter, there will I go for the benefit of the sick. That is the purpose of medicine, to benefit the sick and to act with integrity, without any act of seduction or wrongdoing. To treat everyone, male and female, bond and free. That is a remarkable thing. Some 4 centuries BC in ancient Greece. I'll start with some definitions, and you'll see how these definitions vary over time. Euthanasia, direct, deliberate killing, with the presumption that that is for the alleviation of symptoms. Voluntary, if it's done with the consent of the patient. Involuntary, if it's against the wishes of the patient. Non-voluntary, if the patient hasn't consented. Physician-assisted suicide is where the doctor prescribes and usually administers and supervises the administration of lethal medication. Assisted dying is a term that I don't like, but it was the term used with the Maris Bill. It covers euthanasia, physician-assisted suicide, and the various substitute forms, alternative forms of euthanasia. Any legislation thinks about safeguards. And if you think about them, they are rather limited in number. There's not an indefinite number of safeguards. Age. Usually adults, but not always, as we'll see in the Netherlands with the Groningen Protocol. In Belgium, you'll see that the law allows pediatric euthanasia. Capacity, the ability to make a decision free from duress. Some form of medical consultation to determine the nature and condition of the patient, why they are suffering, their likely prognosis. Possibly a second psychiatric opinion with regards to the question of capacity or to help define the underlying conditions. Then, as I've said, the prescription of the lethal medication is required. And then the rather interesting question, if the doctor is prescribing the medication, supervising it, does he have to kill the patient if it's not successful? And the question of certification, of course. Very often it's a natural death. Then some sort of medical and/or judicial scrutiny, and we'll see how that works in Belgium and Holland. The law necessarily has to decriminalize this killing, because the essential problem is, how can society, particularly if it's abolished the death penalty, allow one group of individuals, be they doctors, nurses, paramedics, to kill another group within society and within the law? That essentially is the problem. It has to be, as it were, decriminalized. And then there is the question and meaning of conscientious objection, not only from the point of view of the profession, of individuals, but also, as we'll see, organizations as well. Let's look at Holland. Holland has a long-standing case law on this, starting with the Potsdam case back in 1973. And Dr. Posma gave a lethal injection of morphine to her mother, who'd had a stroke and wanted to die. And as you can see, the court recognized that this was a legitimate use of medication to, quote, shorten somebody's life. So she got a suspended conditional jail sentence of 1 week. The next important case was the Schönheim case, 1982 to 1986, but you notice that the Royal Dutch Medical Association stepped in 1984, and you see the coalescence here of case law and professional advice through a professional body. A 95-year-old lady, not terminally ill, expressed a desire to die. And this was justified by the court under the principle of necessity, Article 40 of the Penal Code, to overcome her suffering, to prevent her suffering. The only case in British law that has used the principle of necessity for killing was, of course, the conjoint twins case. The Pauls case is interesting because Dr. Peter Admiral has become a staunch supporter of euthanasia, and he was involved in the killing of somebody with MS, almost completely paralyzed. And he was, the court ruled that he was grappling with difficult issues in relation to a justifiable consent, in their view, to overcome his suffering, overcome the suffering of the patient. The Dunger case, which you can read there, case of depression. Somebody who tried to kill themselves. Somebody who had a problem with alcohol abuse. She was mentally competent and had repeatedly requested to die. She also wanted to die, interestingly, for the sake of her family. Is that a legitimate reason for wanting to die? Closer to home, I'm a gastroenterologist. The Cause case. Dr. Cause was a paediatrician and brought about the death of a patient of his with anorexia. And this is interesting because the court accepted that you could allow euthanasia for psychiatric illness. The Chabot case is also interesting because Mrs. Beauchamp had experienced the bereavement of two of her sons. One from suicide, the other from cancer, both at the age of 20, and she died as a result of a grief process some 4 months after the death of her second son. But it's also of interest because of the issue of a second opinion. In this case, 4 opinions from psychiatrists, none of whom saw the patient. One, indeed, thought that the euthanasia was inappropriate so soon after a bereavement. Then we have termination of the life of newborns in the case of Prinz and Kedjic. Both cases, doctors were charged with murder. But the Justice Minister thought that the cases were suitable vehicles for securing legal clarification. And the doctors were acquitted because they had acted with due care, under the due care criteria, professional criteria. And then the case of Dr. Van Olgen falsely certifying a death as a natural death back in 1997. And he got a very lenient sentence of 1 week conditional imprisonment and a 2 years probation. You get a sense here of how euthanasia is being regulated in Holland and the slippage away from those who are capacious and adults. But the Dutch law has always said that you've got to have a reason. And the reason doesn't necessarily have to be a medical condition or a medical illness. It can be a psychiatric illness. This just summarizes some of the statistics in Holland. On the left, you've got 2004, the right 10 years later. You notice that the notifications, euthanasia and physician-assisted suicide, have increased dramatically from 1,800 to over 5,000. I think the figure now is over 6,000. The majority in the early years, if you look at the 2004 column, were for organic disease, cancer in particular. Very small numbers of cerebrovascular disease, neurological disorders, and pulmonary disorders. If you look across, however, you see this interesting case of dementia, mental disorders, multiple pathology. So the numbers of cases of euthanasia through dementia has gone from 42 to 97 to 81, very comparable to the non-cancer medical diagnoses back in 2004. You also see an increase in euthanasia for mental disorders and multiple pathologies, which essentially means multiple pathologies predominantly in a geriatric population. This is very interesting. In Holland, the ratio of euthanasia to physician-assisted suicide is about 10 to 1. But you notice, in 2010, it's nearer 20 to 1. And that is because probably when you've got well-established euthanasia, or PAS, the population wants the doctors to do it. And as a case law, and as the professional guidelines go back a couple of decades, the Dutch people are much happier to allow the doctors to kill them, and they don't so much want to kill themselves. But if you look down the column, you see that there's been an increasing tendency for doctors to make decisions towards the end of life. The percentage, however, of ending life without explicit request, which was certainly an issue with the Remling report back in the 1990s, has fallen, but there's been an intensification of the alleviation of symptoms over that period and of foregoing life-prolonging treatment. So that you can see in the total column that the percentage of medical decisions towards the end of patients' life has increased from 39.4% to 57.8%. Dying has become much more medicalized. If you just look back to the euthanasia rate between 2001 and 2005, you see it goes down 2.6 to 1.7% of deaths. Now, why was that? Well, in the mid-2000s, the Dutch discovered terminal sedation. Usually that means withdrawal of treatment, withdrawal of hydration and nutrition, and the provision, often by syringe driver, of analgesics and sedatives. So they discovered terminal sedation. In this country, of course, with the Liverpool Care Pathway, we had discovered terminal sedation, deep sedation, if you like, much earlier than that. And that probably explains the dip in the euthanasia rate between 2001 and 2005, but it then increased again. And you see also that there is this question of what to do if the patient doesn't want to eat or drink. The place of euthanasia in Holland is interesting. Most of them occur at home, not in hospital or in hospices. And the majority of cases, of course, are carried out by what we would call general practitioners, although they are beginning to have their euthanasia clinics. The question of dementia is interesting and worrying. The numbers have increased, as I've said, but in 2013, when there were 97 cases going through the Euthanasia Committee, the scrutiny body, none of them went further. They were all regarded as having occurred with due care. There must be no prospect of improvement, and the physician in some way or other must be able to empathize with the patient's condition. So we're beginning to see now more cases in relation to dementia and to mental illness where the patient has capacity, but it is deemed that they have an incurable condition which is going to go on, and increasingly we are going to see cases of euthanasia for dementia and for mental illness. Kind of says what I was saying a moment ago. Around about 2010, nobody quite knows, but perhaps 4 to 10% of cases of terminal sedation, but that has increased. And is often associated with cessation of hydration. Helga Kruse, back in 1984, said that if you dehydrate somebody, if you withdraw hydration and nutrition, people will soon realize what a terrible thing that is, and they will want terminal sedation. So you see, 20 years after that, terminal sedation in Britain and in Holland. But what is also very interesting and slightly worrying is that aside the question of euthanasia, this can be an alternative. A few months ago, I drilled down to see what the professional advice was from the Royal Dutch Medical Association, KNMG, and the Pharmaceutical Association. How do they go about euthanasia? How do they go about terminal sedation? It's really quite chilling when you read this. Must be absolutely certain that a patient is in a deep coma when the muscle relaxant is administered. The use of a coma-inducing substance recommended in the guideline in the correct dosage is crucial in order to ensure that the patient cannot perceive the effects of the muscle relaxant. The Dutch, at least, are quite honest about what you should do if you are in attendance. The physician must remain with the patient or in his immediate vicinity until the patient is dead, with physician-assisted suicide. They recommend a maximum time of 2 hours with the family and the patient. And if the patient does not die within the prescribed time, the physician must perform euthanasia. Was that ever really addressed with the Maris bill? Would the consultant or the GP have been held negligent for prescribing lethal medication? And then the patient vomits it up, is worse, goes into a coma, but doesn't die. Would they be negligent? Would you have a negligence claim against a doctor who didn't kill his patient? At least the Dutch, bless them, a little bit more honest. The reporting is a problem, whether it's, or however it is done, whether it's before the death or after the death. And it has been shown, both in Holland and Belgium, that there is significant underreporting. So the Euthanasia Committee in Holland, and there are 5 regional ones, only see those cases that are referred to them. And there are many reasons why doctors may not wish to report euthanasia. And as you can see there, in Holland, between 1981 and 1997, their euthanasia law came into being in 2002. There were only 20 prosecutions, and only 6 were given a conditional sentence without imprisonment. And that harks back to where I began with the case law. So the actual numbers of cases that go through the scrutiny committees and have any sort of judicial review are vanishingly small. And that may be one reason, of course, why they are a little bit lax about reporting to these authorities in the first place. But what about the decisionally incompetent patient in Holland? A patient who can't make a decision. See, it can arise if you have a condition and you then go on a ventilator or go into ITU. The view was that you had to be suffering. And how can you suffer if you're unconscious? And then the view became, well, you may be put on the ventilator as a result of your underlying disease. And then the view became, well, wouldn't it be unreasonable to take the person off the ventilator or reduce the sedation just to see if they're still suffering? You can make the presumption that they still are. So if the patient has indicated that they would wish to die, then you have the situation where at the time the euthanasia is practiced, they are incompetent, but they have, in a sense, agreed to euthanasia through a sort of advance directive. And as you can see there, the physicians have got to decide. They look at the case, they look at the notes, they see if the patient might be suffering or would be suffering before making the decision as to whether or not it would be their wish to have euthanasia. So we get slippage here in Holland in relation to competence, in relation to assessment by other independent practitioners. We get slippage in relation to children. We get slippage in relation to what it really means to have a fixed and determined wish to die. We get into the business of allowing it in through advance directives and not by scrutinizing it very much. Neonatal euthanasia is practiced under the Groningen Protocol, which is a professional protocol. And it was estimated that there were 15 to 20 cases a year, falling to 3, possibly because of the more widespread use of prenatal ultrasound. But again, if you follow the protocol, unlikely to be prosecuted. Conscientious objection. Well, that's all right, provided you refer. But there's another issue around this. Supposing you've got a patient, you're discussing euthanasia, don't think it's suitable. Well, what about the alternative? What about stockpiling of drugs? Telling the patient how they may bring about their own death, for example. So there's a problem with conscientious objection. There's a problem with referral. If you're not prepared to do something because you think it's wrong, deliberately taking the life of a patient, then is it right, morally, logically, ethically, professionally, to get a colleague to do it for you? This is interesting. Professor Theo Bohr, who had been on one of the 5 regional euthanasia committees from 2005 to 2015, and as you can see from that quote, he's changed his mind. One in 25 deaths is a consequence of assisted dying. Public opinion has shifted dramatically towards considering assisted dying as a patient's right and a physician's duty. As I said earlier, in Holland, they want you to have euthanasia rather than physician-assisted suicide. Get the doctors to do it. And the pressures on the doctors, and doubtless the pressures on the patients, can become intense. What about Belgium? Well, Belgium didn't have a long history of case law. They didn't have a long public debate about the subject. But of course, many in Belgium and Flanders are culturally similar to the Dutch, the others more culturally linked to the French. And as you can see, a dramatic increase in adult euthanasia from just after the legislation in 2002 up to 2012 in that graph. Dramatic increase, particularly in Flanders. And that's the law. It allows euthanasia, interestingly, not assisted suicide. It defines it. It may be performed when the patient is unconscious. You have a right of conscientious objection. If you don't follow the protocols, you may be in trouble, but that's a very small number of people. Emancipated minors may be subject to euthanasia. To date, there haven't been any cases. But they have, interestingly, legalized, positively legalized, childhood euthanasia. And the cause of death is the underlying condition. Don't need to worry that you've killed the patient. It's the underlying condition. Now, why in Belgium and Holland is scrutiny so poor? Well, Dr. Willem Distelmans is the president of the Belgian Federal Euthanasia Review and Evaluation Commission, but he is their leading advocate for euthanasia. And as you can see, out of 8,000 cases, no prosecutions. But that may change. Because of the case of Dr. Mark van Hoey and his patient, the 85-year-old Simona de Moor. That was picked up by an Australian documentary. Going on to conscientious objections, it's not just individuals. It can also be institutions. And many of the care homes, nursing homes in Belgium are run by the church with public funding. That can be a problem. And the case is where we didn't allow euthanasia in a Catholic nursing home. So conscientious objection is not just going to arise in relation to individuals, but also organizations. And Dr. Distelmans explained it, as you can see in that last quote. If the right to euthanasia is refused, that will be a problem, and we will see very shortly in that case. What is interesting is, of course, Europe has abolished the death penalty, but take the case of Frank van der Bleeken, a convicted 51-year-old rapist and murderer who had been imprisoned for 30 years, and he wanted to die in order to meet his mental anguish and was due to undergo euthanasia in January 2014. It was refused by his doctors. Ban the death penalty. But what about those prisoners who want to kill themselves? That's a different matter. And you can see the incoherence of this, the difficulties, the ambiguities, the changes in the law and practice over time. That's Dr. Mark van Hoey, and that is his patient, 85-year-old. Dr. Mark van Hoey, leading practitioner of euthanasia in Belgium, claims in this film to have performed hundreds of cases of euthanasia, chairman of Right to Die. Simona de Moor, 85-year-old, not terminally ill. In fact, if you watch the film, quite a sprightly, intelligent 85-year-old, no history of mental illness. What was her problem? Unbearable suffering after the death of her daughter 4 months previously. Treated by Dr. Mark van Hoey unsuccessfully. She still wanted to die. She was motoring around in this nursing home, having breakfast, talking to her friends, going on an exercise bike. On the day that she died, her friends couldn't face her over breakfast, so she wandered round and said goodbye to them. She got herself on her exercise bike and then went into the room to see Dr. Mark van Hoey. And it is quite worrying how he approached that. General practitioner, not a psychiatrist. He was the judge as to whether or not she was suffering a grief reaction, which of course she was. And he decided it was the right thing to do for her in her circumstances. And if you watch the film, you're struck by the sheer banality of what he did. And in fact, it's probably because he allowed the Australian crew in to see what he was doing that he is likely to be prosecuted for that. One of the first in many, many thousands of cases. What about Oregon? If you look at the reasons for assisted suicide in Oregon, and as you know, a lot of the Morris bill was based upon the Death with Dignity Act, you will see that we have created a different class of patients who undergo medical suicide, so to speak, as opposed to spontaneous suicide. They are completely different demographically, as I'll hope to show in a moment. And why do they want assisted suicide in Oregon from the patient's point of view? Those are overlapping percentages, of course. But at the top is losing autonomy, ability to engage in activities, loss of dignity, loss of function, burden to others, and then inadequate symptom control, and occasionally financial implications. If you look at spontaneous suicides in Oregon very briefly, you see a completely different picture. A larger number, mainly males, who kill themselves with firearms, 62%, as opposed to 31%, then poisoning, hanging, and falling. The others are much less common. But of course, with assisted suicide, it's lethal medication. As we all know, those that undergo so-called spontaneous suicide, for want of a better term, and I mean no disrespect using that, very high percentage of patients, both in the States and in Britain, with mental health problems, social problems, and difficulties. And these are probably underestimates of mental health and other social and interpersonal problems. Different group of patients altogether. And they have a lot of other problems, as you can well imagine, a lot of psychosocial problems, for example, and suicidal behavior. Very interesting, in the very week that the Morris Bill was being discussed, National Suicide Prevention Week as well. What is our attitude towards suicide? And that again illustrates what we already know in medical practice and psychiatric practice. You tend to be depressed if you want to kill yourself or suffer from mental illness, particularly psychosis, bipolar disorder, and schizophrenia, for example. This is interesting. This is the number of deaths in red from 1998 to 2014 and the number of prescriptions. So you see that the number of prescriptions, the number of deaths has more or less increased, but there's an absolute increase in the number of people who want assisted suicide, get the pills, but don't take them. 105 deaths compared to 155 prescriptions in 2014. And this is the insurance policy issue, and begs the question of what do we really mean by a fixed determination to kill yourself? That's an interesting slide. It shows the fall in euthanasia in New York City. Isn't that odd? But look carefully at the slide. Nothing to do with humans. It's animals. A fall from 31,000 to 6,000 deaths, euthanasia in animals. Bucks the trend, doesn't it? But people tell us, I wouldn't let an animal suffer like that. Well, in New York City, neither would they. Much more heroic in terms of treating animals and reducing euthanasia. So what have we got? A rather schizoid approach to suicide, making it more difficult to help those that need help, but facilitating assisted suicide, and even creating a new category of medically assisted suicide. The Maris Bill was remarkable. It completely bucked the trends. The trends in Europe, North America, certainly the trend which I won't talk about in Canada. This is the British Parliament at its best. Read the debates. A most remarkable result. We have, through Parliament, defeated for the moment and possibly for a generation the idea that we are going to introduce euthanasia into this country. A remarkable result. Defeated 330 to 118. Got 650 MPs, so that would still be a majority if every single one had attended Parliament. As you can see, the familiar types of safeguards: over 18, resident in England or Wales, don't want Dignitas problems over here, terminal illness, expected to die within 6 months, clear, voluntary, settled, informed wish to end their life, witnessed, countersigned by 2 doctors in the High Court of the Family Division. And what are they supposed to do? Well, supposed to tell you that the patient is terminally ill, that they have mental capacity, they have a fixed and determined wish to die. What's interesting is that in the Maris Bill, there's no question about unbearable suffering. It doesn't come into it. And they've got to be satisfied that they have been informed of alternatives such as palliative care, and most of those dying in Oregon have had access to palliative care. But as I say, it doesn't require the person to be suffering which is interesting. And then there's got to be a cooling off period, 14 days, before they take the medication. And that is supervised by a doctor or a nurse. Problem of unbearable suffering, of course, is difficult because it has both an objective component, and what is the nature of the suffering and the pain that the person has, but also a subjective component. But as you can see from the experiences in Holland, for example, the subjective component often is foremost. I'm going back to the beginning. Stick to the Hippocratic tradition. Absolutely essential that doctors, nurses, the profession, do not directly and deliberately kill their patients. That is what medicine is emphatically not about. It is there for the benefit of patients. And that's illustrated by that quote from Margaret Mead. Doctors have enormous power, for good or bad. The person who can cure you can kill you. We must never cross that ethical Rubicon at all. But once you do that, although we haven't done it in this country, you do it in Holland, Belgium, Luxembourg, Oregon, Vermont, is it easy to retrieve that situation? There are false distinctions, as I've said, and tried to illustrate, between euthanasia, physician-assisted suicide, and assisted dying. And one of the interesting issues surrounding this whole thing is, well, what do you do if you can't apply for euthanasia? You haven't got the time because of the cooling off period. You don't want to go through the bureaucracy. You've got a patient who's still got problems. Or even euthanasia has been refused. Or you haven't even discussed it with the patient. What are you going to do? There are other alternatives around this in relation to cessation of treatment, cessation of hydration and nutrition, and the provision of terminal sedation, for example. Seen in Oregon that increasingly the sense of loss of control, the need for some sort of insurance policy, is now regarded as a reason for euthanasia or physician-assisted suicide, just in case. Now, how on earth, logically, can that be reconciled with the idea of a fixed and determined wish to die? It only becomes fixed when you do die. And general practitioners and physicians like myself will have known many patients who at the time, quite clear they wanted to die, failed in their suicide attempt, and lived to regret it and didn't repeat it. The role of the doctors is an issue. Should we be telling our medical students and junior doctors that if you want to enter medicine, you've got to be prepared occasionally, once a year, twice a year, to kill your patients? What is it going to do to the profession? What is it going to do for vulnerable people? What is it going to do to the interrelationship between the profession, doctors, and society as a whole? And as you can see, in Oregon, they have increased the number of suicides, created a new category of suicide as well. A normal reaction to the knowledge of severe illness, and particularly terminal illness, as described by Dr. Kubler-Ross, is denial as the first stage, then anger and frustration, then some sort of reconciliation, and possibly, finally, some sort of acceptance. If you get people shortly after a diagnosis of incurable cancer, they may be in denial or they may be angry, and they're more likely to want to kill themselves. That's part of the natural history of the psychological, and one might say spiritual, reaction to catastrophic news. So Dame Cecily Saunders talked about total pain to describe the physical, the psychological, and indeed the spiritual pain that is experienced by those who are known to be suffering from terminal illness or severe illness. What's the degree of capacity that you need to be absolutely sure that you want to kill yourself? That is an extraordinary decision to have to make. And presumably it would require a very high degree of mental capacity. Do you really know that you really want to kill yourself on a particular day? One of the lies to all of this, of course, is the insurance policy argument. So I hope I've shown that this is changing the attitudes to suicide, the kill or cure dichotomy, and even the creation of new categories of suicide, and an acceleration even in the numbers of suicides generally. We are rational beings, but we are also relational beings. All this is happening within the context of society. It cannot not affect the profession and society at large. There are problems with prognosis, as my friend and colleague, Professor Pulicino, pointed out in 2012. It is very inaccurate. One might even ask, why should it matter if you're going to die anyway within a certain period of time? But there is often this idea, as with the Maris Bill, that you've got to have a certain prognosis, usually less than 6 months. But there's a danger here for any clinician, as we all know, which is illustrated very well by this quote from Dr. Elizabeth Kubler-Ross, one of the pioneers of the palliative care movement in America. I would add that we should not give up on any patient, terminal or not terminal. It is the one who is beyond medical help who needs as much, if not more, care than the one who can look forward to another discharge. And as my mentor, Dr. Margaret McKerrow, who worked at St. Joseph's, said, the most important person on your ward round or in your clinic is the dying patient. Never walk away from a dying patient. And for 40 years I've tried to live by that. It doesn't matter who they are. They are the most important person on the ward round. You don't put them in a side room and forget them. They are the people that you need to approach and talk to and involve. The dying patient is the most important patient that you have to deal with. We must never be complicit in direct, deliberate killing, but we must also be mindful, if there is legislation, of the effect on voluntary organizations who may not be able to function if they have public funding and are not prepared to kill their patients on their premises. And we will see this perhaps in Belgium shortly and in Canada shortly. So I go back to the beginning. This is a very simple issue. It's not difficult. There must be an absolute prohibition of direct, deliberate killing and assisted suicide. It's quite extraordinary if you look in depth at the legislation, at the professional guidelines, how incoherent these arguments become, how contradictory, how differently they are applied in different jurisdictions. One of the first casualties here is language, but also logic, philosophy, morality, professionalism. And I hope that I've gone some way to illustrate how when you are doing something which is fundamentally wrong, according to natural justice, fundamentally wrong according to medical practice, you get or become incoherent in your thinking, in your perspective, and you go off in all sorts of directions. My advice to you is don't. Thank you very much.